Welcome, everybody. This is Mark Lynn with Healthcare Business Specialist, and this is the 201 session for Rural Health Clinic Billing this year. We're extremely lucky to have Patty Harper with us, who is going to present on some of the more advanced level sorts of things. I know I'm negative reimbursement. We get a lot of questions about that. So a lot of the more Medicare secondary payer, Patty is going to be talking about that. The slide presentation is in your handouts. There's also a brochure in there for InQuiseek. So Patty and Jeff have this great product where you can house all of your RHC policy. So that brochure is in there as well. The session is being recorded, and the slides again are in the handouts, and they are also in the on our website and the Facebook page. So Patty, I will leave it up to you. Tell everybody about InQuiseek and InQuiseek, and we'll just listen in. Thank you very much for doing this.
Okay, thanks, Mark. Welcome, everybody. I'm so glad to be here. As you can tell, all of us are so passionate about rural health, and Mark is especially good about bringing us all together. So here at InQuiseek Consulting, we do just about everything RHC related except for cost reports. So you'll need to talk to Mark and Danny if you have cost report issues. We do not do that. And we also do have our compliance service, which is InQuiseek. And so if you have any questions about that, we will be more than glad to let you know how we can help you out there. We do have a lot of content today, and so some of it is informational, some of it we will not dwell on, but if we're going to cover it, we better all get started. So thank you and welcome to the webinar, and we appreciate you joining. Hopefully most of you were able to be in Amanda's webinar earlier this week, the 101 session. So we are going to pick up kind of where she left off. We may do a little bit of a recap in case you're joining us for in the middle of this series. This is our beautiful clinic. The picture here is our beautiful clinic in Del Rio, Texas. They're letting us use the picture with permission. So these are the things that we're going to try to cover today. Hopefully we can get to them. You'll have an opportunity to ask questions or put them in the chat box, however you want to do that. But we're going to talk about just a little bit about the Medicare reimbursement methodology and the claim format. Some of that was covered on Tuesday, but we're going to just touch base on it again. And then we're going to spend a good bit of time on the Medicare deductibles and coinsurance and how the crazy way those deductibles work for RHCs, how that ends up at the first of the year giving you some really squirrely looking remittance advices that have recoupments or negative amounts on them. And then we're going to go into some advanced billing topics as you see listed here. So we have a lot to go over, and so let's just go right into it. In case you weren't on the earlier webinars, because this is a series of 5 webinars, I think, all total, including the test. We're going to go back over Medicare reimbursement for RHCs because it is a very different thing. And so rural health clinics are paid on a cost-based reimbursement. Mark talked about this, Amanda talked about this. So if you're in a medical office or you were a medical office previously before you were an RHC, you were paid a certain amount based on each CPT code. And that's still the way that you're paid by your commercial payers in RHCs. But for Medicare and most of our Medicaid payers, we are on a cost-based reimbursement methodology. So we have to get our heads around the fact that we are being reimbursed per encounter. So that's very important to kind of get that in our heads, that every year when we do our cost report, it's our total allowable cost divided by our total qualifying visits, comes up with an all-inclusive rate. That is as close as we can get to what it actually cost you to provide an episode of care. So when we think about things in the RHC, are we getting paid for something? Are we not getting paid for something? It's very important to change our mindset to this. We're being paid per visit or per encounter. And then I know you had a slide on Tuesday that was very similar to this. So an encounter has a specific definition. It is going to be that face-to-face between a qualified provider and a patient for a medically necessary service gives us an encounter. And so starting in 2022, we were able to capture mental health telehealth visits as an encounter, and we're going to have some slides that go into that a little bit later. So you'll see over on the right side of this slide, CMS is going to then reimburse us. Y'all, rural health clinic math gets really wonky. So we say we get paid an all-inclusive rate, but actually our Medicare contractor, whether that's Palmetto or Novitas or any of the other Medicare contractors, is only going to pay us 80% of our all-inclusive rate. And the wild card in our payment is going to come down to our 20% co-insurance. So we're going to talk a lot about that when we go through some actual payment examples. But this is, we are being paid per RHC encounter. So I hope that makes sense, because it is crazy math. So all right, so even though our claims go out as an institutional provider, we go out on a Part A UB claim, even though we send out Part A claims, our services are actually Part B services. And Mark talked about this a little bit in the intro webinar. So it's a little bit crazy. So if we have a patient who does not have Part B Medicare benefits, if they are Part A benefits only, then services in our clinic are not covered for them. So our patients must have Part B Medicare, and then Part B deductible applies to our services. So it's a little bit crazy. As I said a minute ago, the Medicare contractor is going to pay 80% of the all-inclusive rate. And then the patient is responsible for, now get this, 20% of the total charges. So if you're in a fee-for-service arrangement, it's usually 20% of an allowable. In a rural health clinic, the patient responsibility, the co-insurance amount is 20% of the total charges. So charges really matter. We're going to see that as we go through a few examples. And then the other tricky thing is, so CMS holds us responsible for collecting any unmet deductible directly from the patient, but we're not allowed to keep the difference between that deductible amount and our all-inclusive rate. So this is where our negative take-back comes from at the first of the year as those deductibles are being met. So we have to collect the deductible against total charges, but we are not allowed to keep the difference. We can only keep our full all-inclusive rate. So the Medicare contractor is going to pay you your full all-inclusive rate until the deductible is met. And after the deductible is met, then the Medicare contractor is going to pay us 80% of that AIR, and then the wild card is going to be the co-insurance that is 20% of the total charges. So this is a different ball game. It's very confusing when you start seeing these remits come in, and it can be challenging in posting these amounts and getting everything to balance. So somebody asked me on a webinar that I did for the state of Oregon earlier this week, well, who came up with this crazy payment system? Who came up with this crazy deductible and co-insurance methodology? And it came straight out of the Federal Register, the federal code that started RHCs. So if somebody questions you about it in your revenue cycle department, or somebody else just doesn't understand it, you can take them back to this regulation. This is where it all started. So yes, it's a little crazy, but it's right here for us, and it has been the way it has been since the RHCs were started. So this will go back to if you have to prove to somebody else this crazy world we live in. So RHCs are going to be held to the 2024 Medicare Part B deductible. And this coming year, it's going to be $240. So that's an increase of $14 over what the deductible amount was last year. All of your Medicare patients have been notified that this is going to be their deductible amount. Many of you know that I just had my Medicare birthday in September. So I just signed up for my Medigap policy yesterday, got my drug plan all in place. And so I'm trying to navigate this from a patient perspective now, and it really is very, very different. So this $240 deductible that will start January 1st is applied to total charges. So it's not tied to our all-inclusive rate. It's tied to total charges. And so, as I said earlier, the RHC is responsible for collecting the full deductible if the full deductible has still not been met and your charges equal or exceed the $240, you're going to be responsible for collecting the entire deductible amount. If your charges are less than the 240, then you're going to collect probably your total charges for that patient. If they don't have a Medigap plan or a secondary that covers that Part B deductible. So the fact that we have to be the debt collector for CMS, we have to be the deductible collector for CMS, but we are only allowed to keep our ARR payment. So that is what creates the negative amounts on the remits, or what we call negative remits. It's going to look like it's a recoupment or a take back. And so when we're posting that amount, we have to be very careful to leave the correct patient responsibility on the patient account. Sometimes we're tempted to try to make cash balance, and sometimes we will reduce the patient responsibility amount, and we don't really want to do that. And we'll talk about some posting tips in a minute. For those of you who are in provider-based rural health clinics, you just may want to know that the Medicare Part A deductible for 2024 also went up this year. It went up from $1,600 to $1,632. So this does not apply to rural health clinics. The Part A deductible does not apply to rural health clinics. The Part B deductible does. But if you're in a provider-based rural health clinic and maybe you do things on the hospital side and the clinic side, you just might need that information. Okay, so moving along, we're going to look at some actual examples, and these are also in the slides that you have gotten. Okay, so let's look. So we have an example at the top. So we have total charges of the $240. So it just happens that our total charges for this RHC encounter equal the complete unmet deductible amount. So what is going to happen is those total charges, that entire $240, is going to be collected as the deductible. Since the deductible is just now being met, there is no co-insurance due on this visit. But as you can see in the green line on the first example, we're assuming that we are an independent rural health clinic. We haven't gotten our new 2024 rate yet, so we're still going to use the 126 as the upper payment limit. And so Medicare is going to ask us to give them back $114 on this visit. And so they're not really asking us, they really pretty much just take it from us. And so there's different ways that this can look. Sometimes the take back will be on the same remit as the visit, and sometimes it will show up a little bit later. So it's a little bit hard to keep up with. So again, we are responsible for collecting the full deductible total charges against the full deductible, but we can only keep our all-inclusive rate. And since the deductible is just now being met, Medicare is going to pay us that full all-inclusive rate. So that's our first example. In our second example, also the deductible has not been met, but our charges are only $195. So this is going to also illustrate, these are the same exact services at different charge amounts. And I'm not suggesting any specific charge amounts. I'm just trying to illustrate that the amount of your charges does directly affect the co-insurance part, or the deductible amounts and the co-insurance amounts for the visit. So it's very easy for us to either not be charging enough, or actually we can outprice ourselves from the market and make our services so much more expensive for our patients that they choose to get service somewhere other than a rural health clinic. So setting prices is very important. We have to be very careful when we talk about setting prices. But there is a sweet point where we do, want to get that pricing at the right place. So in our second example, our charges are $195. So the entire $195 is going to be collected against the deductible. It's not going to meet the full deductible, but it is going to be put against the deductible. Again, because the deductible has not been met, there will be no co-insurance. But again, we can only keep our all-inclusive rate. So in this example, our take back is less because our charges are less. And so we're going to have a $69 negative amount that we're paying, that difference between the deductible we collected and our all-inclusive rate. So these are situations where the deductible has not been met. So the long and short of it is we have to be the debt collector for the deductible, but we're not allowed to keep the amount, that the difference between those total charges and that are the deductible and our all-inclusive rate. We do have some extra examples in another document that explains this. So if you're still really confused when we're done with this part of it, you can email me and I will send you some additional explanation that we have. But I think it makes more sense to actually look at examples. Okay. And let's, so now we're going to, where? I'm missing a slide. Okay, now we're going to look at this slide, which are examples of where the deductible has been met. So we're not having to work with the negative remits on these examples. We're actually working through what our gross reimbursement for this visit is going to be. So I'm using the $195 of charges in the first example. So the deductible has been met. So in this case, our Medicare reimbursement is going to be 80% of our 126 all-inclusive rate. And then the co-insurance is going to be 20% of the total charges. 20% of 195 or 39. So our reimbursement for this visit is going to be $139.80 if we collect from Medicare and we collect the patient responsibility, either from the patient or from their secondary payer. Our maximum possible reimbursement for this encounter is $139. So you'll notice that's above the 126 all-inclusive rate. So sometimes we will get less than our rate. Sometimes we will just about break even on our rate, and sometimes we will be paid a little bit more than our rate. The total charges and the co-insurance piece is the wild card in the formula. And if we look at our second example, we have $115 worth of charges. Again, we have the same services, just at different dollar amounts. And I am not suggesting any particular pricing or fee setting methodology. In in this case, we're going to get the 80% of the AIR. We're going to get the $100.80 from our Medicare contractor, but our coinsurance is going to be reduced because it's 20% of 115. So the more your charges are, the higher your charges are, the more coinsurance your patient will pay. This gets to be really tricky. These are independent clinic examples for our clinics that have grandfathered rates that are much higher. They really have a hard time because if their charges are not high enough, they won't always come close to meeting their AIR. So these are what your normal remits are going to look like after deductibles have been met. And so, and the ones before looked like the ones with the negative remits when the deductible had not been met. Okay. All right. So when we're posting negative remits, we want to make sure that we leave the full deductible amount on the patient account as patient responsibility. Often we're tempted to write off part of the patient responsibility to try to balance cash, and we really want to leave that on. So whatever adjustment that you make for the negative remit, it's going to be made outside of the patient account level. So I hope that makes sense. It's not going to be an adjustment that hits that patient account on an individual basis. It's going to have to be an adjustment that helps you balance cash, and that's going to be either through a special adjustment category that you set up. Some people set up a clearing account where they can post all those negative remits and they can balance them through a clearing account. It will not be adjusted off at the individual patient account level. And so, and then when we adjust that, we are going to reduce revenue, which is going to be a debit to revenue and a credit to either cash or another offsetting account that we will use to reconcile those differences. So not trying to make accountants out of all of you. I was an accountant in a former life, and I had to think twice about my debits and credits here, but I think I got them right. Mark can correct me if I got them wrong, Mark or Danny, all the accountants on the call. But anyway, you want to be really careful if you're using any kind of auto posting features, because sometimes they can get really creative on how they make things balance. And so if you have e-posting, you're going to want to make sure, especially at the first part of the year, that those deductibles and those recoupments for the deductible amount are being made correctly. And if you have a brand new billing company that hasn't worked with RHCs, or you have an RCM partner, you need to make sure that they understand this deductible situation at the first part of the year. I've actually seen quite a mess when it wasn't understood and the patient responsibility amounts got really messed up. Also, you need to work with your front desk so they understand this on a level that they can answer questions with the patients, and need to have some kind of process in place for collecting something up front from traditional Medicare patients that don't have a Medigap plan or don't have a secondary payer. Because we're going to be responsible for collecting that. Medicare is going to already have taken their part of it back. And so it's always harder to collect money on the back end than it is the front end. So have that discussion with your front desk about how they need to handle questions about deductibles. Your patients all know they have deductibles, not just your Medicare patients. Everybody knows they have a deductible. And so we need to be able to talk openly about it. We can't leave Walmart without paying for our milk and bread. So we need to be able to have those same transparent conversations, that you can't come to our clinic and not work out something with us for the amount that you owe. Um, So sometimes small towns, rural health clinics, small towns, we know everybody, we're more reluctant to ask for upfront payments. But we've already had to pay Medicare their amount, and so we need to get that back, so that we're not hurting for cash flow either. Okay, no, jumping right along out of the negative remits. I don't know if there's any questions about the negative remits in the comments so far. If there is, if somebody will remind me, we can look at those.
Hey,
Okay.
Patty, I've been answering the questions as we go along, but at the very
Well,
end,
great.
I'll ask them to you, and then we'll check our answers and see if I got them right or not. So, but
Okay,
you
all
just
right. Oh, that'll be fun. Oh, I like
okay,
that,
all
Mark.
right. You
That's
just go
fun.
ahead, but and there's not been any negative reimbursement so far. Thank goodness. So
Okay, all right. Well, that's fun. I like that game. Okay, so
okay,
I'm going to take just a minute to look at the claim form and kind of recap some of the basics that Amanda went over Tuesday, just in case you missed that one and you're joining us in the middle. Okay. Seems like I'm frozen up here. Okay. So when we do bill on a UB04, also known as an 837I, or also known as a CMS 1450, and so we have lots of names for our claim form. So this is the top section of our form. The blue fields are mandatory fields for your claim. Red ones are not required, and ones that are in black or gray are optional. So we're going to talk about the fields that are needed for Medicare secondary payer at the very end of the presentation. And then we move to the middle part of our claim where we're actually listing the charges. This is where our CG modifier goes, our revenue codes, our CPT codes, and HCPCS codes. I know this was covered on Tuesday. And then the bottom of our form, these are the things that we need. We do have this document available to share with you. I did not give it to Mark before the webinar, which I should have, but you can email it. And we also have another document that lists it out by field locators. We talked about that information being in Chapter 9 of the Claims Processing Manual, but I think the document I have is one that I adapted from Janet Litton, who used to be very well known in the RHC world, and I've kind of expanded on what she has. So again, if you're getting a system configured for RHC billing and you have questions about how that configuration needs to be set up, we certainly would share those documents with you. Okay, and we all know that we have different types of code sets. We're not going to go over this slide, but it's going to, if you have questions or your staff has questions about the different code sets that we use, this is just a really quick cheat sheet that explains the type of codes. It's always interesting to me. We always get people who get ICD-10 codes and CPT codes mixed up, or get Category 2 HCPCS codes confused with CPT codes. There's a lot of codes, and if you're going new into RHC billing, some of these code sets you may not be familiar with. So this is just a great little cheat for you. Again, I'm just going to recap the main places where our RHC encounters can occur. Amanda did a great job of this on Tuesday, but here it is for you, just all in one place as a recap. And then the split billing, I know, was also gone over on Tuesday, but I wanted to just also include these two graphics. I think they're very easy to understand. We have one for independent billing and then one for provider-based billing. And do remember that your 6 required tests are separately payable through split billing. Probably twice a week, someone will show me a claim example and they have the 6 required tests rolling up on their UB claim. And there's a couple of reasons why that's not the correct way to do it, but just know that even the 6 required tests are separately billable. So here's our independent split billing chart. And here is our provider-based RHC split billing chart. And so those split bills go out on the hospital side just as if they were a hospital outpatient service. So just those might be helpful for you to have all in one presentation. And I know that you also discussed the CG modifier and the roll-up of charges. I'm not going to really go over this slide, but I do have a new slide that I'm kind of excited about that I am going to share with you. And so here's a claim example that shows the roll-up. And I know that this was explained in the 101, but and here's another claim example. I'm trying, and this is, I'm getting ahead of myself. I'm so sorry, guys. I'm so excited about the new slide that I'm skipping ahead. So here's an example of the CG modifier and the charges rolling up. This is a great CG modifier FAQ document, and I've put the link on the bottom of this slide. I have heard that this document may be taken down off of the CMS website, even though it is still valid. So they're trying to clean up some stuff they have out there that's older. And so if you do not have this document, I would go snag it, save it to your desktop, put it in your RHC billing Bible, however you keep up with all of this stuff, because it may vanish off the CMS website and not be easy to find. And it answers all the super important questions about the CG modifier. This is the slide I'm so excited about. Sorry, you can tell that we're all RHC nerds. We were having that discussion earlier today. So this is just, do I put the CG modifier on the claim or do I not put the CG modifier on the claim? And so I think it's a really handy slide. And so when I see that I left out the very bottom one on the Medicare Advantage plan. So we always have to have one CG modifier on our RHC UB claim, only one. But there are times when we have two CG modifiers, when we have a medical and mental health visit on the same day. When we have a mental health encounter by telehealth, we still need the CG modifier. I wish this was interactive. We could play a question and answer game on this. And so this is just going to go through and give you a scenario and tell you whether you do or do not need the CG modifier. So the simple part is, if the service does not pay the all-inclusive rate, if the service does not pay the all-inclusive rate, it does not get a CG modifier. So if I have those things that are paid off of a fee schedule amount, I don't have a CG modifier. So with that FAQ document in this new slide, that should answer most of your questions about if you need a CG modifier. We get a lot of questions about that. So one time when we do need two CG modifiers is when we do have a medical visit and a mental health visit on the same day. And so, and in that case, both lines get a CG modifier, nothing rolls up to each other, and we will receive two all-inclusive rate payments. So that's a time where we use two CG modifiers, when we have a medical visit and a mental health visit in the same day. Here's an example. We get a lot of questions about this. People are trying to get those wellness visits in before the end of the year, particularly if they're in any quality reporting program. So if we have a sick visit or a medical visit on the same day as we have a Welcome to Medicare exam, the IPPE, I just had mine 2 weeks ago at a rural health clinic. So if we have the Welcome to Medicare exam and a sick visit, the CG modifier goes on the medical visit, goes on the 99213, the E&M code. We do not put any modifier on the Welcome to Medicare exam, the G0402. We will be paid 2 AIRs for this situation. This is the only time that you will get 2 payments for a sick visit and a preventive service on the same day. So if we have a sick visit with the annual wellness visit, we still report it. Remember, we report everything that we do. We need that annual wellness visit to go on that patient's common working file. We need that patient to get credit for that visit. So if you can do them separately and it's appropriate medical management of that patient, you can do them in separate visits. But if the best thing to do is to do them together, we still report everything that we do. We will only receive one all-inclusive rate payment, one encounter rate for this service. Co-insurance will only be due on the E&M code. So there'll be $20 of co-insurance due for the sick part of the visit. There is no deductible or co-insurance on the preventive service, which is why we do not roll it up to the CG line. Anything we roll up to the CG line is going to calculate deductible and co-insurance. So we never roll up a preventive service, but we always report a preventive service because Medicare needs to know that the patient had that service. They need to know that we performed that service. Okay. All right, other modifiers. And some of this is in the FAQ document for the CG modifier that you'll see, but we're just kind of going over some of it. So RHC claims to traditional Medicare will not typically use 25 or 59. So you die-hard coders out there that would want to put a 25 on the E&M when you also had injection administration, we don't do that on RHC traditional Medicare claims. We do not use 25 or 59 in the conventional ways. So we do use 59 in a very special way to report two unrelated visits that happened in the same day. So again, if you have a new billing company, you have a new RCM partner, make sure they know that on the UB traditional Medicare claims, we do not use modifier 25 or 59 in the conventional ways. And we do not report 25 or 59 with the CG modifier. So that is actually in that FAQ document that I shared with you a few slides ago. We can get overpayments. There are certain Medicare contractors that whenever there's a 25 or a 59, they're going to automatically trigger an extra overpayment. You would owe that back to them as an overpayment. So again, we do not use 25 or 59. If you have 25s hard-coded on anything, you really want to watch that. Okay, this has really nothing to do with anything, but I didn't know where else to put it, and I thought it was really something that we needed to cover. And that is, since 2022, we have been able to bill professional hospice services if our RHC provider is the attending hospice physician. So when a patient enters hospice, they are entering a end-of-life care model, and hospice pays for everything related to that hospice admission. So in rural areas, often our medical director at our clinic is also the hospice medical director or the attending hospice physician. In that case, we could bill those hospice services as an RHC encounter. And so in those cases, we would use the CG modifier in the new GV modifier, CG and GV. Now, what I'm finding is most of the hospice organizations already have arrangements with those medical directors and often don't want that revenue to be shifted to the RHC for those professional services. But I have seen where some rural health clinics are billing those as hospice, but it's going to take some collaboration with the hospice organization. If we treat a hospice patient, if we look at the right side of the screen, if we treat the hospice patient for a non-hospice related service, then we can get paid for that. We must append a 07 condition code up in the top section of our claim form, and we must put a GW modifier with a non-hospice diagnosis. So if I have a hospice patient with lung cancer and we're treating their lung cancer, that's a hospice service. if I have a sprained ankle for that lung cancer hospice patient, then I could put condition code 07 and the GW modifier on it. The cancer diagnosis would not drop on that claim, only the injury code. And so those are the two ways that we can bill hospice patients in the rural health clinic. And this is a MedLearn Manners that goes over that. If you don't know how to pull these MedLearn Manner articles, they are great. And this is the one on hospice. Okay. It got put on my list for this webinar to talk about incident to services. We've got about 20 minutes left, so let me see if I can make some sense of this. So we use the words incident to, in my mind, two different ways when we're talking about rural health clinic billing. So incident to just means a service provided subsequent to or related to another service. So when we talk about incident to services being bundled in our encounter rate, we're talking about things like nursing services, bandage administration, med administration, things that our provider might not personally do, but they are professional medical services that are done as part of that encounter or as part of that provider's treatment plan. So these services are all reported on our UB claims. We do not get separate reimbursement for any of them. So examples would be a blood pressure check, an injection-only service, an uncomplicated bandage change, or a suture removal. So something that a nurse is able to do, they're doing it as part of the extended service of the RHC provider, but we know that we don't have a billable encounter when we don't have a qualified RHC provider. So we do have a benefit. We do have a benefit, and we have an incident to service. So that's one definition of incident to. That's all of the things that go into working out that treatment plan for that patient. The other thing that gets a little trickier is incident to physician billing. Billing incident to a physician, which means that the nurse practitioner or the physician assistant is billing under the physician's NPI number. Now, there's really no reason for us to do this in a rural health clinic because all of our provider types are all reimbursed, our all-inclusive rate. Sometimes you will still find people are using incident to billing either as a credentialing gap, or maybe some of the contracts they have are in the doctor's name and they haven't credentialed the nurse practitioner or the physician assistant. And so we're running everything through under the physician. When the RHC program started 40 years ago, almost 50 years ago, we saw it more often because not all insurance companies were credentialing mid-level providers. And so we didn't have a way to actually get contracted with those plans if we didn't do it through the physician. Now, everybody has the ability to have their own NPI number. Every provider can be credentialed and linked to your contracts for your rural health clinic. So if we are still billing under the physician, just be mindful, it has to be an established patient with an established problem. The nurse practitioner or the physician assistant is making no independent medical decision-making decisions. So they are just extending the care plan that the physician implemented on that initial. So you have nurse or physician assistant who is seeing patients, new patients, existing patients for new problems. They are exercising their own medical decision making, and it is not appropriate to bill incident to the physician. So I've had that crop up lately, people that got their systems set up years ago and still don't have those providers billing under their own numbers. So hopefully incident to services and then incident to physician billing. Two different things. Both of them have incident to in the description of them. Both means they're following something or they're related to something that was already done. So hopefully I didn't make a mess out of that too bad. Okay, I know Mark talked about immunizations in the intro webinar. I didn't see anything in the webinar from Tuesday on immunizations, just because we are in the middle of flu and pneumococcal and we are seeing COVID cases pop up. Just a reminder that these never go on claim. They are cost settled on the cost report, as Mark explained really well in his first webinar. So we don't even want those dropping on your bill at a penny. Medicare tells us, and it's actually in the Medicare administrative guidance, that it is inappropriate for RHCs to put the flu shots, the pneumococcal shots, the COVID shots on the claim, even at a penny. They do not go on your claim at all. They are one of the most common billing errors reported by the MACs. And so if you want to track those so that you can reconcile them to your logs, you want that code to be set up where you can charge it, but it does not drop to the claim, or you need to have some other kind of a dummy code set up for utilization tracking, but we don't want those on the claim, not even at a penny. If we're doing Hep B, it is one of the rare adult immunizations that is incident to our RHC visit. It is reported on the claim, but there is no additional reimbursement. This one gets a little tougher. Tetanus, when given to treat an acute injury, should be able to be reported on the RHC claim, but routine tetanus is a Part D benefit. So if you have a provider that's just trying to make sure that those patients have had that tetanus every 10 years, then you're going to want to make sure that they understand that that's a Part D benefit. We are not going to be reimbursed for that in the rural health clinic from Medicare. There's a great immunization Part D fact sheet that CMS has. And if any of you need it, I should have linked it here and I did not. Everything else that is an adult immunization is a Part D benefit. And so if you can use a third-party vaccine management vendor or a third-party vaccine biller, please let your cost report preparer know that you have that arrangement so that they will know which vaccines that third-party company is handling and if there are any that need to go on your cost report. Okay, I gotta hurry here. There are a few things that are exceptions to face-to-face encounter requirements. These are things that go on our UB claims, but they do not pay our AIR. So if they don't pay our AIR, our CG modifier does not go on them, anything that doesn't pay. So all of these pay a consolidated fee schedule. There's a lot of changes to care management in the finalized 2024 physician fee schedule rule, including the addition of some community health and primary care navigation services that will fall under G 2025. We are going to be able to bill for more than one G0511 in a month, as long as the resources don't overlap. So we're surely hoping that CMS gives us more guidance on this. What do they mean by no resources overlap? So if we're doing chronic pain care management, and we're doing remote patient monitoring, but we're doing remote patient monitoring for diabetes under chronic care management, do we have any overlap in utilization between the care management and the patient monitoring? So hopefully we'll get some more guidance. All of the fee schedule amounts for 2024 are going down. So because we're a consolidated fee schedule amount for G0511, and we've added more CPT codes to what goes under that umbrella, our payment for care management services is going down $5 for 2024. But all of the fee schedule amounts are going down because there is a reduction in the conversion factor that they use when they calculate the physician fee schedule. So for 2024, we should see a reduction in all of these fee schedule services, including our telehealth. Okay, here's care management when we bill it by itself. It doesn't have a CG modifier because it doesn't pay the rate. And if it happens that we're reporting a care management service at the same time that we are reporting an office visit, they can go on the same claim, and this is your example for that. Okay, telemedicine for 2024, trying to get to the end here, guys. Got 10 minutes. I have a lot of content here. So we can continue to bill for distant site medical telehealth through the end of 2024. So distant site means our provider's at the clinic and the patient is somewhere else. Now, the provider can be at home or can be somewhere else, still under some flexibilities, but the patient, it's our provider and the patient is somewhere else in most cases. Originating site is we are hosting the patient in our clinic, but the telehealth provider is another separate provider not attached to our RHC that is somewhere in a bigger city. So our payment right now for G2025 is distant site. So that's our provider providing that telehealth service to a rural health clinic patient. We had a little problem about a month ago. They took the CS modifier out of use as far as how it was related to COVID, and they didn't realize that we still needed the CS modifier to waive deductible and co-insurance on a preventive service. And so we've got that fixed, I think. So we would put a CS modifier on our G2025 when that represents a preventive service. That way, no cost share to the patient is there. But no CG modifier goes on any of our medical telehealth claims. Okay. Right. Here's a Med-Org Matters that's been revised a number of times. Make sure that you have the correct one. There is a new list of all of the telemedicine codes that are approved by Medicare. This is not a rural health clinic specific list. What I want us to pay attention to here is on this list, though, it tells us whether it can be an audio only service or not. So we notice that our E&Ms, none of our E&Ms can be audio only. And that just makes sense, right? But our preventive services can be audio only. And so when we're doing those preventive services, we're putting that CS modifier on the G2025. If our patient doesn't have a computer, they don't have a smartphone, they don't have internet, they don't have broadband, whatever their technology limitation is, these services can be audio only. These services can't be audio only because we choose for them to be audio only. We still have to have the ability for two-way audio visual telemedicine. Okay, but our mental health telehealth does count as an encounter, and it does have the CG modifier. We also need one of two other modifiers, a 95 or an FQ modifier. And I know I'm running so close here. And here's our Med-Org Matters. We are still limited to the 7 mental health codes that are on the qualifying visit list for these communications. But we can add now our professional counselors and our marriage and family therapist. So if you're adding those to your clinic, they will not have a Medicare enrollment. You can enroll them now with the 855I or through PACOS. They'll have to be enrolled as Medicare providers before you start billing for them. But great news for mental health. again, if you need more mental health examples, you can email me. Okay, gosh. Okay, Medicare secondary payer, we could have a whole webinar on this because it is very complicated. But there are situations when Medicare is not the primary payer. It's somebody who's the working aged, which I would fall in that category now. If I'm working and I have commercial insurance through my company, then Medicare becomes secondary. Or I have a workers' comp claim, I'm in a car accident, those are the primary payers instead of Medicare. And so, who knew, but there is a whole Medicare secondary payer billing manual. It is right here with the link on the bottom of the screen. It will tell you every situation where Medicare secondary billing applies. And then it will go even further. And in section 50, it will show you the data elements that are needed. Now, we don't work very closely with NGS. They are one of the Medicare contractors, but they have the best Medicare secondary payer billing examples that I have ever found. And it's a pretty current presentation. The link for that presentation is on the bottom of the screen. And so rather than try to reinvent the wheel, I would point you to this. It's publicly available whether they are your Medicare contractor or not. And then, but we do report condition codes, which are the circumstance that related to the Medicare secondary payer claim needing to be created. And these are some of the common ones that we use. Those are going to populate in the top part of your claim. And then we have occurrence codes. Again, conditions codes, occurrence codes, and value codes. They give Medicare information about what's going on with this claim. Why was this claim created? Why is this an MSP claim? And so this gives you occurrence codes, gives more information about the event that triggered the claim. And then actually, this is from that MSP manual, actually goes through and tells you which value codes are valid and what the situation is that applies to them. Again, we could do a whole webinar on this, but I just wanted to introduce you to these resources. And Mark, I think I'm done with 4 minutes to spare.
Okay, hey Patty, great job. We have a ton of questions that I've been trying to answer. Before we go into these questions that we're going to ask Patty, first off, thank you for doing this. That was fantastic. I probably didn't listen to it as much as I should have because I was answering questions. But in our chat, Paige Chambers has put in there a link to an Amazon wish list. This is Patty has her daughter passed away in a tragic fire a couple years ago, and Patty and Jeff run a pantry and they feed a lot of people. Patty was telling me that they filled up the pantry 4 times yesterday. So I always try to, whenever I jump on Amazon, I always try to send a few things over. Thus my wife and child have their cart filled up. If it's empty, I will tend to send some over there to them. So it's a good thing to do at Christmas to go and share the bounty that we all have. So if you would do that, that would be great. Make sure to copy that link before we stop here. So Patty, what I've done was I've tried to answer the questions the best to my humble abilities, and let's see how we do. We probably have about 15 minutes of questions, so we'll do this quickly. What if? Okay, let me make sure I'm at the first one here. What if we only submit the amount of our all-inclusive rate instead of sending our normal fee? Is that possible?
So I just had this come up last week. Somebody had gone in and changed all of their qualifying visit codes to their rate amount. So we are instructed to report our normal and customary rate. So I don't know how everybody else feels about it. You really need to be reporting your rate, and in my opinion, you need to charge every patient the same amount. So we agreed to receive different amounts from different payers, but I certainly would not, for Medicare, submit your all-inclusive rate. I would submit the actual customary charge. Mark, do you agree with that?
That's what my answer was. Betsy, that's possible, but it's not correct. You should not be doing that. You charge based upon CPT code. Do not charge based upon your rate. So, and I apologize.
Some Medicaid, yeah, I'm sorry. Some
No, I was just
Medicaid
saying, I'm
plans.
sorry about the tone. I noticed after I was typing these so fast that my tone got a little bit off on some of these too. So I apologize for that. Go ahead, Betty.
No, that's fine. Some Medicaid plans do want you to report your actual rate with the T1015 code, but Medicare, we are instructed to report the customary charges. So
that's absolutely correct. I forgot about Medicaid. The T1015, that's usually your rate. So, okay. Next question is the $240 deductible per patient, or is the deductible for charges for the for the entire? It says facility. I thought it said family, but for the entire facility. But is it $240 per patient? I guess is what the question is. The deductible.
Per Medicare patient, per traditional Medicare patient.
Yeah,
that is the Part B deductible. That's whether they're in an RHC, not in an RHC. That's for all Part B Medicare services. The patient is responsible for the first $240.
Yeah.
Good question.
I said per patient. So I thought it said per family, but it's really said per facility. But if we set up the E&M code as my AIR and submit any extras, is that not correct also? What you want to do was just set every E&M code to the same charge there. And
you don't want to do that. You really don't. It's against the directions. It's not going to calculate the co-insurance correct, because the co-insurance is supposed to be off your customary charge, and you're not going to be paid. And you don't, in my opinion, you should not have two different fee schedules. You should have one fee schedule. Everybody gets charged the same amount. So if you're setting that E&M at your AIR for Medicare patients, but your commercial patients get a different charge, then you have a compliance issue that you're not charging the same thing for all services too. So we agreed to accept different payments from payers, but we always charge the same. From a compliance perspective. So Mark, we're all on the same page on that.
Yeah, I answered exactly the way you did. I'm just gonna say, if I answered the same, I'm just gonna say I answered you the same, because it's gonna take a long time to get through this if we do it that way. So okay. And then this one here you may not remember. And for example, one from a cost report perspective, would we owe that difference back to CMS? And when I looked at example one, that was because the copay and the actual payment that was made to the rural health clinic was actually more than what the AIR was. It was $139 they received in cash, and the AIR amount was $126. And what Sarah was asking, would that reduce your cost report settlement? I'm a cost report person, so I'll answer that one real quick. Is no, that would not. The copays do not go in that little settlement piece on C Part 1 and C Part 2 as a reduction in that. So the more you can collect on your copays, the better off you are. Is that the way you see it as well, Patty?
It is, and that's part of this crazy RHC math, right? We're not going to exactly get the same amount for each encounter. That co-insurance is the wild card piece, but that's also why it's so important not to have your prices set too high, because your patient is going to realize if it costs more to come to your clinic than it does to come to a non-RHC clinic down the road. And so, we're in the commercial fee-for-service world, we just write everything off as a contractual adjustment. The rural health clinic patients and critical access hospital patients have a higher co-insurance. So we can't just globally keep increasing prices, because who will feel it will be our patients.
Let's see, next question on here is
Medicare secondary
one I did not know. I was just like, I don't have a clue. Does the Medicare deductible also apply to patients when Medicare is secondary payer?
So it does, and that is part of those value codes that we report that I went over very quickly at the end, because you're going to report either what you actually received, and you're going to report the total expected reimbursement. But yes, the Medicare deductible can be applied to those claims in certain circumstances. So it's a little bit of a long and drawn out thing. You have to go out to the patient's common working file. You have to see if there's a Medicare secondary payer case set up out there, and there is a formula for Medicare getting their deductible at least taken out of anything that they would owe. It's pretty complicated, but yes, the deductible can be applied to Medicare secondary payer.
Okay, that's what I put. I thought that it would, but I wasn't sure on that one. Okay, next question. So we don't show the rolled up lines as 0.00. We keep the amounts on the line but we roll up on them. But we keep the amounts on the line, but roll on the amounts to the first line. I think what she's asking is it okay to roll up the full charge for those Incident to services, or is it appropriate to use, and you can't use 0.0, you got to use a 0.01 in order to make it work.
I agree with your answer, Mark, on that one.
Okay, great. Yeah, it's just basically it's your choice.
You can report it either way. It's going to depend on your system sometimes on how that roll-up function is configured.
Okay. The next one is, do you have to have an RHC encounter qualifying visit to bill a technical component on a data service? And they're talking about an EKG, a 93005. Are you still there?
I'm still there. That's a tough one.
Yeah.
Let me see.
I was thinking the 93005, I mean, that's a technical component. It seems like you could bill that to Medicare Part B and get paid fee for service, and then keep the 93010 piece of it and bill it incident to if you have a visit that occurs within 30 days, which I'd assume you would if you're having an x-ray on somebody, or an EKG on somebody.
Yeah, on the EKG example, I think that's doable. Where we get into trouble is sometimes with a lab only draw, where then we're sending the lab out. We don't end up with really anything at all, since the venipuncture has to go on the UB claim. But I think for the EKG, I agree with that answer completely.
Yeah, that's so dumb. I hate it when they changed that back in 2014, that 36415. It just didn't make any sense to me that's considered, if a venipuncture or a blood draw is considered to be a professional service. So it's an incident to service. So
yeah. And then this next question about the cash pay, I would charge them the right amount and then make a self-pay same day adjustment for that difference. Is how I would do it. So I think I agree with your answer on that one too, Mark.
Yeah, what I would do if you're doing stuff like that is rural health clinics can automatically qualify for National Health Service there's a site you can automatically qualify as a site for National Health Service Corps, and that's going to help you to recruit nurse practitioners and PAs and physicians because National Health Service Corps has a ton of money, and you would actually qualify for this. So I would get your sliding fee schedule set up and apply to it, and then try to get some loan repayment. Because believe me, I have a child in PA school. We need loan repayment in these places. So okay.
Right.
Next question. I didn't have a clue on this one about liability and all that. So you want me to read that one? When liability auto shows up in the common working file, what is the best way to get it reprocessed to Medicare?
Well, so we must have the same diagnosis or the same accident date on the claim that's in the secondary Medicare payer file. I'd have to know more about that specific situation to see what's triggering that denial.
Okay, we'll go 2 more minutes here because we'll go 10 minutes over because I do have to leave. I've got a plumber showing up at our house, so I've got to go over and take care of that pretty soon. So we'll go ahead and we'll go till 2 minutes is up. And it's ask here, Patty, if you have a sample RHC Medicare secondary claim that you could send to them. So if you do have one, send it to me, and I'll put it in the package that I send out. Everybody, you will be getting slides tomorrow. You'll get a recording of this session as well if you had to leave early or something like that. And if you need to show it to other people, and we'll put the slides in there. And then Patty, if you'll send me any of those resources that you talked about during the session, I will send
that
it out
link to the NGS webinar is the best thing that I have found so far. It's pretty clear.
Okay. I'll have to watch it. I didn't even know that was out there, so I'll definitely watch that one.
Yeah.
Let's see.
And I agree on the flu shots.
Yes.
So this next one is on incident 2 billing. If you have a payer that still actually insists for you to bill under the physician, then I would get that in writing from that payer, because that is not following general compliance for billing right now. So if they're listing the provide, I don't even know where you would put that. So there were a few holdouts, like some Cigna plans that still were requiring incident to physician billing. I thought everybody was past that now. If a payer wants that, I would verify that with them. If they told you that 10 years ago, I would ask for the answer today, because it could be that now they are credentialing nurse practitioners. Like I said, there were a couple of commercial plans 15, 20 years ago that did require that you bill under the physician with some modifiers. I would verify it. I would get it in writing, and I would make sure that this is still how they want it set up.
Okay. All right. Well, I've got 2:10 now, Patty. I think we probably ought to cut it off here. And
okay.
Thanks everybody for joining us, Patty. Thank you for the presentation. It was fantastic. And join us next week. Charles James will be here next week to present. I think he was actually in the audience. I meant to open up his line, but I got so busy answering questions that I forgot to do it. So he could chime in as well. But we'll talk to Charles next week. Everybody have a great weekend. Patty, thank you very much. And we'll talk to everybody later.
Thank you.
Okay. Bye, Patty. Bye, everybody.
Bye.